As usual, the source for this presentation is from UpToDate and NCCN. Okay, so we're going to cover urology cancers, bladder cancer, and kidney cancer. We'll start with the bladder cancer. I'm trying to move the top. Can I just move this to the bottom, or how we do this? Okay, good. تمام. شكرا عبد الله. شكرا عمل عبد الله. Perfect. Bladder cancer. Bladder cancer is considered the most common cancer of urinary system in the US and Western Europe. It is typically urothelial carcinoma. Other parts of the world is urothelial or non-urothelial due to schistosomiasis. Risk factor for the urothelial: cigarette smoking, half of the cases, chlorination of water, arsenic, and some occupational, especially in industrial chemicals, paint, plastic, rubber, leather, textile, and these are the other risk factors for the urothelial bladder cancer. Phenacetin, I put it there, but it is now actually worldwide, it's being removed from the market. So the non-urothelial is either non-urothelial, either epithelial, like a squamous carcinoma, which is typically in the schistosoma hematobium epidemic region, like in Sudan. Adenocarcinoma, small cell, these are the non-epithelial right here. The risk for the non-epithelial, the chronic infection and inflammation, chronic UTI, E. coli, and Proteus mirabilis, which change the urine into nitrosamine, which is made highly carcinogenic, causing bladder cancer. That is the reason why we see non-urothelial due to chronic infection or inflammation, radiation therapy, smoking, cytoxin, schistosoma hematobium. 90% of non-urothelial is squamous cell carcinoma due to the schistosoma hematobium infection. Could be adeno, it could be urothelial too, but typically is squamous cell carcinoma. Presentation: painless hematuria, irritative voiding symptoms, frequency or nocturia, dysuria. Diagnosis: the diagnosis of bladder cancer, as you can imagine, is by cystoscopy and biopsy. When you do that, you may find just positive cytology without lesions, but you could find a non-muscle invasive lesion or muscle invasive lesion. Urine cytology, and you may have the opportunity to do urine biomarkers. There are some tests now available. This is mainly done by urologists. Fluorescence cystoscopy is helpful in case of papillary tumor and carcinoma in situ. Transurethral resection of bladder tumor, TURBT. Examination under anesthesia, EUA. Then definitely we will reach diagnosis by these procedures. And of course, imaging of upper urinary tract, either CT or, either CT scan or MRI. For the initial evaluation, for the early stage bladder cancer, you will need histologic grading and depth of invasion to determine the stage of the cancer, and that is helpful for the stratification and treatment of the disease in its early stage. CT scan and MRI, upper urinary tract imaging, PET scan, these are this is for the initial evaluation. So when you have the biopsy, you need to go over the pathology with your pathologist to look for the depth of invasion, because that is considered the most important prognostic variable in determining risk of recurrence or progression. So you need an adequate biopsy. So when you get a biopsy from cystoscopy from a urologist, the first thing you want to make sure that there is a muscle in the specimen. That is very important. It has to be a muscle in the specimen. Otherwise, you are not going to be able to stage the patient properly. And of course, you are not going to be able to treat the patient properly. So adequate biopsy is crucial for your treatment and for the stratification and to decide on your treatment, if not metastatic, of course. Differentiation, you look for the differentiation of the cancer cells, and then you divide the specimen into low grade, high grade. Of course, high grade has an aggressive natural history. T2 tumor, that invasion of the muscle, is considered a high grade carcinoma regardless. Low grade versus high grade is important for risk stratification and management of non-muscle invasive disease. So the grade is very important. So two things you need on your biopsy. To get a biopsy report, your biopsy should have a muscle, number one. Number two, that's with the muscle, you determine the depth of invasion, of course, and then the grade. If it's a T2, the grade is not really necessary. As long as muscle invasion, that is a high grade. This lists the depth of invasion. You can read it here. The hallmark of the depth of invasion is the T2, which is the invasion of the muscle. If it is present or not present, that is define your next step. So you do need a muscle in the specimen. This is a staging. This is a TNM staging system. Then we're going to dive into the treatment. So going to be a lot of data and literature here. So please follow very closely. And I really appreciate if you could participate in the questions, because I like to do the cases, and the case maybe keep us awake and follow the slides. So in this presentation, I'm going to focus on urothelial bladder cancer, not the others. So mainly this is mainly for urothelial bladder cancer. So case number one, a 73-year-old male patient with history of diabetes, CKD, chronic kidney disease, and severe eczema, poorly controlled with topical remedies. He presented with dysuria, hematuria, cystoscopy revealed a fungating tumor in the trigone of the bladder. Biopsy revealed no muscle present in the specimen. However, it showed a high-grade invasive urothelial carcinoma extending into submucosa. He is referred to by his urologist to help with the management. So what would you do? What would you recommend? Would you recommend to do an MRI of pelvis with and without contrast so you can look at the bladder? Would you recommend sending the specimen to check for FGFR, which is the fibroblast growth factor receptor, by PCR, or for HER2 by IHC, immunohistochemistry? Or would you request a repeat cystoscopy with TURBT? Or would you recommend to treat, as long as this is a high-grade invasive urothelial carcinoma, to treat with intravesical BCG or chemotherapy? So if you choose, before we go in, if you have someone in the chat, which one you choose? Let's say number 3. Okay. Oh, well, I forgot one, or radical cystectomy. Number 5. So there's another option. So someone already chose number 3 to repeat a cystoscopy with TURBT. So now, for treatment, these are the modalities for treatment: radical cystectomy with urinary diversion, and these are the options for the urinary diversion: either ileal conduit or cutaneous continent reservoir or orthotopic new bladder. Another modality is intravesical instillation and systemic therapy, which could be an antibody drug conjugate, ADC, or immune checkpoint inhibitors, or chemotherapy, or targeted therapy. Those are the modalities of treatment, or of course, radiation therapy. So these are the things that we're going to cover, depend on the stage, depend on the situation. So indication for cystectomy, long list. So the most important one is muscle invasive tumor, a T2 muscle invasion. Then cystectomy, radical cystectomy is indicated, and these are the rest of the indication for the non-muscle invasive. Of course, are all for non-metastatic disease, of course. So either a T2 or non-invasive with a specific criteria which some of them are a strong indication, some of them are relative indication. But of course, if the patient is symptomatic, not managed with medically, pain, incontinence, hemorrhage, then cystectomy is done for that reason, for symptom relief. So we're going to start with the non-muscle invasive urothelial bladder cancer. So for the non-muscle invasive bladder cancer, the best treatment is TURBT, transurethral bladder tumor resection, transurethral resection of bladder tumor, and that will lead you to the risk stratification. Remember, we said we need that will tell us about the depth of invasion and the differentiation, the grade. So for low grade, if you do TURBT and there is no muscle invasion, and it is a low risk, low grade, then single installation of intravesical gemcitabine is recommended. So Gemzar is considered for the low risk. And then, of course, after that surveillance, and the urologists, they have their own protocol for how frequent they do during cytology and cystoscopy. We'll leave that to urologists. I don't think we're going to be asked about that in any exam, the frequency, but we need to know that this is all urology stuff. For the intermediate risk, like grade 2, then after TURBT, induction with the intravesical administration of gemcitabine for 1 year. Induction and maintenance for 1 year with the gemcitabine and surveillance. For the higher risk, we do the same TURBT, but for the higher risk disease, we use BCG installation, intravesical BCG with the maintenance for 3 years. Of course, for the very high risk, grade 3, high risk, radical cystectomy is indicated. So these are the treatment for the non-invasive bladder cancer newly diagnosed. So we talk about the gemcitabine or Gemzar and BCG. There are now new intravesical therapy that is we need to know about because we may get involved because of the nature of the actually it shouldn't be intravesical. Actually, pembrolizumab is not. I think it should. This is not intravesical. This is IV. Should remove that. Okay. Anyway, sorry for that. It's not intravesical. It's pembro. This is intravenous. So intravenous pembro, we may get involved with IV pembrolizumab for certain situation for the non-invasive. So just remember, this is intravenous, not intravesical, pembro. It is for high risk non-invasive bladder cancer with carcinoma in situ, with or without papillary tumor. Then pembrolizumab intravenous PD1 inhibitor could be used, and that's why we could be as a medical oncologist involved in treatment of a non-invasive bladder cancer, which is typically treated by urologists. Or BCG unresponsive, or ineligible for or have elected not to undergo cystectomy. The patient decided not to have a very high risk, opted against cystectomy, then intravenous pembrolizumab is an option. So that's why we get involved with the non-invasive bladder cancer, because this is usually urology patients. Intravesical immunotherapy, which is for BCG unresponsive. And there is a new drug, which is an IL-50 interleukin-15 receptor agonist, nogabendiquine, which is, or Anktiva, that is given intravesical through the instillation in the bladder. There was an open-label clinical trial for more than 150 patients, unresponsive to BCG. Those patients being given intravesical NAI, which is Anktiva, is given weekly for 3 times, and then as a schedule, in this schedule, and it showed a CR, or complete remission, of 71%, 94% 2-year overall survival. Based on this clinical trial and result, the drug is approved to be used for BCG unresponsive non-muscle invasive bladder cancer. So this now become a standard of care for patients failed BCG, and this is administered by urologists. But we need to know, because also we got involved in the treatment of non-invasive bladder cancer. Intravesical gene therapy. There is another new drug, which is gene therapy for BCG unresponsive bladder non-muscle invasive bladder cancer. Nadofaragene, which is a gene therapy, and this is a non-replicating adenoviral vector gene therapy given intravesically every 3 months. It is recommended for high-risk BCG unresponsive non-muscle invasive bladder cancer with carcinoma in situ, with or without papillary tumor. So now we have 3 new drugs for non-invasive bladder cancer. One of them could give at the medical oncologist, which is the Pembro, and the other given by urologists. So now we're going to switch gear and go to the muscle invasive urothelial bladder cancer, and here we are deeply involved in this kind of this stage of cancer, because the non-muscle invasive were involved only when if the patient require an immune therapy, which is the Pembro. But for the muscle invasive, we actually treat those patients more than urologists. So let's just go into the muscle invasive urothelial bladder cancer, and here the case. First of all, this is the answer for the previous the person who answered number 3. That's correct. If the biopsy not have a muscle, don't be shy and give a call to your urologist to repeat the biopsy and give you a piece of tissue with the muscle. Otherwise, you will be treating the patient blindly if you don't have a muscle. So it has to be a muscle in the specimen. So you need to repeat the cystoscopy as many times as needed with TURBT and get a biopsy with muscle for better understanding of the disease and for stratification and decide treatment. So that's a correct answer. Repeat cystoscopy with TURBT. So the same patient. Now, a repeat cystoscopy has been done, showed tumor involving muscularis propria, so it is a T2, and we have the lab. And remember, we said the patient has diabetes and he had a diabetic nephropathy with the creatinine of 1.7, estimated GFR 39 ml per minute. And you have done scans and showed no evidence of metastasis. So your scans, whatever is that, is CT scan without contrast or a PET scan. But in any case, the patient does not have metastatic disease. That's good. So he is back for a follow-up visit to discuss your treatment plan. So what is treatment modality that will give this patient the best outcome? Choose one. Please choose one. And choose any. It will really be helpful for discussion if you choose an option. So new adjuvant, dose dense MVAC followed by radical cystectomy. New adjuvant, gemcitabine, carboplatin plus carboplatin followed by radical cystectomy. So new adjuvant. Another new adjuvant, immune checkpoint inhibitor, pembrolizumab followed by radical cystectomy, or bladder preservation with trimodality therapy, TMT, which is maximal TURBT and chemoradiation, use chemoradiation, or radical cystectomy with or without adjuvant therapy. See if someone, I'm going to give you 1 minute to choose. Number 2, new adjuvant Gemzar. Number 5, radical cystectomy, adjuvant therapy. Please choose. Go ahead and choose more. I just want to see what people. Number 3, no adjuvant pembro, followed by radical cystectomy. Number 5, radical cystectomy, adjuvant therapy. Number 4, number 2, number 2, number 4, number 2. I would like everyone to choose and see, because this is a real case that you may see in the office for sure. That's a typical scenario. So if you choose, we will learn. Number 3, number 2, number 2, number 1, number 2, number 4, number 2. There is more 2s. No adjuvant cisplatin. Number 3. Okay, I think we can. Okay, there is more. Number 1. Okay, so let's just go on the presentation. So everyone at least have chosen something either in the chat or, but in the chat will be nice. So we'll. Okay, good. So let's just go in. So now we're going to talk about management of stage 2 and 4. Let's start with the workup. So the first step for any stage 2 muscle invasion, the first thing you will need to determine the EGFR. You get your chemistry, get the EGFR estimated, but it is better if you could do the 24-hour urine, so you can collect, instead of estimated, you can get the measured GFR, so you know your creatinine clearance. If you measure it, it's better than estimate, but estimate is fine too. So EGFR estimated, it's okay. And then, of course, you get your CT scan or MRI or a PET scan. You need a CT scan chest to make sure there's no lung mets. If you do CT scan, at least a chest X-ray, a bone scan, MRI. And for stage 3B or stage 4, tumor that invading neighborhood, the adjacent organs, that's at 3B, or stage 4 distant metastasis, or lymph node, even lymph node metastasis, not regional. For those patients, all these patients, you should check for, you should send a specimen for PCR to check for the fibroblast growth factor receptor mutation, and we should check for HER2 by immunohistochemistry, not by FISH, by IHC. So those tests should be done for all patients, stage 3B and stage 4. And we'll see, later on, we'll see why we need those specifically. So for stage 2, muscle invasive bladder cancer, for the treatment, remember, the treatment is curative intent. So your goal is cure. We need to remember that. So, of course, the best treatment is radical cystectomy with urinary diversion. That's a cure. And here are the options for the urinary diversion. You can choose any. But radical cystectomy has shown to improve the outcome. Studies have shown that giving neoadjuvant chemotherapy followed by cystectomy improve disease-free survival and overall survival. So the standard of care now is neoadjuvant chemotherapy followed by radical cystectomy. But for patients who are not candidate for cystectomy or desire to preserve the bladder, of course, the option is trimodality therapy, TMT, which is maximal TURBT, adequate resections, followed by concurrent chemoradiation. And we'll go in detail for those things. So neoadjuvant chemotherapy. Randomized clinical trials has shown platinum-based chemo followed by radical cystectomy lead to significant improvement of overall survival and disease-free survival in this kind of disease, which is the muscle invasive. What is the optimal chemo? This is follow this closely because I see that we chose different answers, and so we need to follow this closely to answer that question correctly. So the optimal regimen is not established yet. However, everyone agreed that is on all studies show that is dose-dense MVAC, which is methotrexate, vinblastine, doxorubicin, cisplatin, with G-CSF support for 3 to 6 cycles is the standard of care. Studies have shown that is a less aggressive regimen, which is gemcitabine and cisplatin, is not inferior and is a good alternative. So there's only two regimen approved for this, nothing else. So it has to be either dose-dense MVAC or gemcitabine and cisplatin. These are the chemotherapy based. So now, question, because in the question that we asked, there was an option for neoadjuvant carbo. So the question, can we use carboplatin instead of cisplatin? Remember, our intention is cure. So this is curative intent. So there is no randomized clinical trial available to answer the question. Yeah, good. Someone already answered that. Okay, so there is no randomized clinical trial available to answer that question. And we learned from using carboplatin in metastatic setting, the carbo was found to be inferior to cisplatin. So you're right. So never use carboplatin instead of cisplatin. So if you treat with the curative intent, do not use carboplatin instead of cis. If the patient is cis ineligible, then you have to look for something else. But do not use carbo instead of cisplatin when you treat with curative intention. So prior to give cisplatin, make sure patient is cisplatin eligible. How? First of all, if the kidney function is impaired due to malignant obstruction, it's okay. Just give some time, relieve the obstruction by urethral stent or percutaneous nephrostomy tube. So really, the obstructive uropathy should be treated first to make sure, hoping that you can improve the kidney function and use the cisplatin. So, and then calculate your creatinine clearance after you relieve the obstruction. So the creatinine, if the creatinine clearance estimated or measured is 50 to 60, instead of MVAC, use gemcitabine and split dose cisplatin, day 1 and 8. Use gem on day 1 and 8, and instead of giving the cisplatin on day 1, split the dose from 75 or 70, give 35 milligrams per square meter on day 1 and day 8. That's a split dose. So give a split dose. That's we're trying to keep cisplatin alive. If you want to treat with intention in curative intent, do everything possible, try to use cisplatin. Until you get to the point you cannot use cisplatin, then we talk about different other options. If the creatinine clearance is less than 50 ml per minute, so that means the patient is cisplatin ineligible, alas. Then the answer is radical cystectomy with adjuvant immune therapy, which is usually nivolumab or pembro. So if the creatinine clearance is less than 50, and remember our patient, the creatinine clearance we said 39. So that means if you go back, we'll go back to the question again. So the bottom line is, do not substitute carboplatin for cisplatin, as someone already answered that. I think 2 people did that. So for stage 2 or stage 3A, this is just a summary. Surgical patients who are surgical and cisplatin eligible, willing to accept radical cystectomy, the best treatment is neoadjuvant cisplatin based, not anything else, has to be cisplatin, followed by radical cystectomy or partial cystectomy in selected patients. But if the patients are not surgical candidate, cisplatin or if the patient are surgical candidate, cisplatin ineligible. So your options are radical cystectomy with and without immune therapy, or bladder preserving TMT, concurrent chemoradiation. So, but radical cystectomy followed by adjuvant therapy is better. The bladder preservation, if the patient chose to preserve the bladder, but if the patient is open to surgery, the best option for the best outcome is from radical cystectomy followed by adjuvant therapy, and we'll go over that later on. So again, do not substitute carbo for cisplatin. So for patients who are not surgical candidate or not willing to accept radical cystectomy, the treatment is bladder preservation, which is TMT, reassess in 2 to 3 months after treatment, and to assess for the response and the outcome. If the patient not candidate for cystectomy or definitive chemoradiation, then your options are limited, radiation or TRBT, which is not the best, but that's what you have, that's what you could do. That's not the best. And then reassess in 2 to 3 months after treatment. But that's not a cure. So the TMT, which we use concurrent chemoradiation, and here are the chemo options, which is the radiosensitizer chemotherapy. The best, again, is cisplatin. The preferred is cisplatin. You can use low-dose gemcitabine for patients who are not cisplatin eligible. You can use low-dose Gemzar or 5-FU mitomycin. There is a study for that. I will share it to you in a little bit. Other recommended regimen is 5-FU with cisplatin Taxol. These are all okay to use. Useful in certain circumstances, taxane, 5-FU, Zolota. Sometimes drug availability not available. So you have, these are the options, but your top is cisplatin. This is the 5-FU mitomycin study. It was done for patients with muscle-invasive bladder cancer. They gave them concurrent chemotherapy with 5-FU and mitomycin. It's typical like anal cancer regimen. I think they found out improve local regional disease and reduce rate of cystectomy, and it's considered acceptable regimen. So who are the optimal candidates for the bladder preservation? To get a good result from the optimal from the bladder preservation, the patient should not have moderate or severe hydronephrosis. Number one. Number two, no concurrent extensive or multifocal TIS, and a tumor should be less than 6 centimeters in size. Tumor should allow for adequate debulking or TRBT. So with this, if you have all these three, the outcome from the bladder preservation is acceptable and actually very good. So question, any role for new adjuvant immunotherapy? Because now everyone talk about immunotherapy, this is the time for the immunotherapy. So because we know that's how successful immunotherapy in a lot of solid tumors, and even for the bladder cancer. But now the question, we try to move it even to the front line, even before surgery. So any role for new adjuvant immunotherapy? There are a couple of phase 1 and phase 2 studies. This is the phase 1 and phase 2 study or the immune checkpoint inhibitor without chemotherapy, just by itself. And it has shown actually a pathologic complete response of 30 to 40%. Excellent. But this is only phase 1 or phase 2. Pure one study, they use pembrolizumab, and this is another study. They use the atezolizumab, and another study for nivo, ipilimumab, durvalumab. So there's a lot interest in immunotherapy for the bladder cancer. This is the study of the new adjuvant pembro with radical cystectomy. You can see here it has been published, and it showed a median follow-up of 3 years. Pure 01 result further confirmed the sustained efficacy of new adjuvant pembrolizumab before radical cystectomy. Of course, they said PD-L1 expression was the strongest predictor of sustained response post radical cystectomy. So there is good result. There are good results. Another phase 1 or phase 2 study. In this group of studies, they did immunotherapy plus chemotherapy. So there was a phase 2 study phase 2 single arm, neoadjuvant pembro and gem-cisplatin with the pathologic complete response of 36%. Another phase 2 study, single arm, BLAST 1, neoadjuvant nivo plus gem-cisplatin, pathologic response 50%. Another phase 2 arm, phase 2 single arm. This is a perioperative durvalumab, Imfinzi. They gave it with gem-cisplatin with the pathologic response of 33%. So excellent results. So going back here, so these are still in, you can see phase 2 or phase 1 or phase 2 studies, most of them phase 2. So it is not, so remember, in that question, there are some option for neoadjuvant immunotherapy. It's good, but it is not a standard of care. Do not use them yet. Still are waiting for phase 3 study to confirm this, or just we need to wait more. So neoadjuvant immunotherapy is not a standard of care yet. It is for a systemic, for the metastatic disease, but not for neoadjuvant. Good option, but it has not been confirmed and not been approved to be used as immunotherapy, at least in the US. I don't know if there are any approval anywhere else in the world, but it is not being used as a neoadjuvant therapy yet. So, any role for neoadjuvant radiation? Can you use radiation to prepare for surgery? Randomized trial showed neoadjuvant radiation did improve local control, however, failed to improve overall survival, so it is not recommended. So neoadjuvant radiation, neoadjuvant immunotherapy are not recommended, at least at this time. So now we go to our question, to our patient. So our patient, we gave a lot of neoadjuvant. Let's see why these are not correct answer. If you go to answer number 1, remember this patient has CKD with the EGFR 39 and MVAC is cisplatin. So this patient is not a cisplatin eligible, correct? So this question, that's why it is the best option, but it is not a correct answer because of the renal insufficiency. Second question, Gemzar carbo followed by radical cystectomy. But you remember we said we never substitute carbo for cisplatin. That's why this option is not the best, because your treatment is curative intent. So that's why it is not a good option. Neoadjuvant pembrolizumab, we said this is only phase 1 or phase 2, so it is not a standard of care yet. At least I would say in the US, it's not a standard of care yet. So using immunotherapy in the neoadjuvant is not a standard of care, so don't use it yet. Bladder preservation is okay, but it is not the best, because the best, if this patient is a surgical candidate, the best treatment is radical cystectomy followed by adjuvant therapy. And I will go over that, but we'll go over that in the next question. So the right answer is radical cystectomy number 5, with or without adjuvant therapy, depend on the outcome from the cystectomy. So now, same patient gonna answer. So now, the patient underwent radical cystectomy, and the surgical pathology showed the tumor extended into the perivesical fat. So it is a T3 pathology, PT3, and 1 out of 7 lymph node positive, so L1. So this is stage 3A. So now, and the imaging showed she has no metastasis, so there are no mets. So you did restaging, still there is no mets, but now he has T3A. This is post-cystectomy. So what is your plan for this patient now? So please answer. So surveillance with serial cystoscopy and imaging. Adjuvant immunotherapy, nivolumab for up to 12 months. Adjuvant carboplatin paclitaxel for 6 cycles. Adjuvant concurrent radiation and gemcitabine. All right, choose. No one? Number 4. number 4, number 2, number 3, number 3, number 3, oh, number 2, number 2, number 2, number 2, number 3. Okay, so let us, even if you have not choose, please choose for yourself, even if you are not telling us, so that will help to decide and see why. So now, let's just talk about the adjuvant systemic therapy in high-risk muscle invasive at cystectomy, like our patient. So now cystectomy is being done. So for patients who had no prior neoadjuvant therapy, and we end up with a PT3, like our patient, or T4, or T3, or T4, or a positive lymph node, if they're cisplatin eligible, of course, we give them MVAC or cisplatin gem, for sure. So if they have no neoadjuvant and they have residual disease T3, T4, or N1 or N plus, then it is MVAC and GEMS or GEMSIS, similar to the neoadjuvant. So if we have not given them neoadjuvant, we give them in the adjuvant setting. But if the patient is cis ineligible, so we give them adjuvant immune therapy, immune checkpoint inhibitor, nivolumab, or pembrolizumab. That's our patient, correct? Who is cisplatin not eligible and not received neoadjuvant. So this is the right question, right answer. So the right answer is adjuvant immune therapy checkpoint inhibitor nivolumab for 12 months. If the patient has prior neoadjuvant therapy and found to have YPT2, T4M plus, then we give them adjuvant immune therapy again, nivo or pembrolizumab. And in a randomized trial has shown that adjuvant pembro improved PFS by 29 versus 14 months. So immune therapy after neoadjuvant with residual disease, immune therapy if the patient is not cisplatin eligible, chemotherapy if the patient not received neoadjuvant, and cisplatin eligible, then we give them MVAC or GEMSIS. Very straightforward. Of course, clinical trial is all the time a good option. And there is no data for adjuvant chemotherapy. So any patient received MVAC or GEMSIS and had surgery, they have residual disease, there is no role for more chemotherapy, no role. There is no data for adjuvant chemotherapy. So don't choose any chemotherapy. It's either immune therapy if available. If it's not available, clinical trial available is fine. Otherwise, I guess you have to just follow up. So there is no role for chemotherapy. You just increase toxicity. So for patient with a T3, T4 node positive, margin positive at time of surgery, you may consider adding radiation, especially for the margin positive selected patient. So this is not for everyone, but everyone should get immune therapy if they are cisplatin ineligible. So here is the answer for our patient, for our case. The right answer is number 2, which is adjuvant immune therapy, nivolumab IV. You can give it every 2 weeks or every 4 weeks. If you give every 2 weeks, it's fine. If you give every 4 weeks, IV for up to 12 months. Stage 3B, this is the more advanced, local advanced. So this is just a summary. If a patient is stage 3B, invasion into the T4 N2, so lymph nodes N2 or N3, down the stage with systemic therapy, reassess 2 to 3 months after treatment. If you get a CR, then consolidation cystectomy or consolidation chemo-RT or surveillance. It's just a summary. If they have a partial response, cystectomy, chemo-RT, or treat as metastatic, of course, or if the patient was treated with chemo-RT, like bladder preservation, reassess in 2 to 3 months after treatment, and if it's CR, follow up. If PR, you can give BCG or surgical consolidation with cystectomy. Now we are done with the urothelial. For the non-metastatic only, we still have a lot to go over. So for the upper urinary tract cancer, like a ureter cancer, urothelial ureter cancer, this is a phase 3 study for the upper urinary tract urothelial cancer, high risk with high risk features, muscle invasive and or node positive. So the treatment is radical nephroureterectomy, followed by adjuvant Gemzar and platinum-based chemotherapy, and that has shown improved overall survival and disease-free survival. Okay, so for the non-urothelial bladder cancer, squam, adeno-schistosomal, unfortunately, there is no enough data. Data are very limited. That's telling us back home there, especially in Sudan, there's not much of clinical trials, but there are a lot of patients. So the material is available, just we need to do clinical trials, I guess. So we can provide everyone else with data, because there is not enough data for schistosomal bladder urothelial cancer. I don't know how the incidence and prevalence of the squamous cell carcinoma في الجزيرة. If anyone has any idea. So for this disease is less responsive to chemo. For patients with localized disease, radical cystectomy and lymph node dissection, no phase 3 trial available. And pre and post-op chemo, not recommended. May consider pre-op RT for schistosomal type. See, there is someone. So for the schistosomal type, we may use pre-op RT. Local advanced squam, consider chemo-RT. Metastatic disease, consider carbo, gem, or Taxol. Basically, not enough data. I think it's just lacking of data of clinical trials is putting us in a difficult situation when to treat non-urothelial bladder cancer, unfortunately. So for the non-urothelial bladder cancer, surgery is the way to go. If no definite, and there is no definite role for adjuvant therapy. Certain patients may consider neoadjuvant or adjuvant RT. Schistosomal may consider adjuvant chemo-RT. Advanced, not candidate for surgery. Palliative care, chemo, not enough data. So now we go into the metastatic therapy. Metastatic disease, systemic therapy is still evolving. So a lot of data. There is a lot of new data for this disease. So now we go to our same patient. Now he completed 12 months of adjuvant nivolumab. You gave him adjuvant nivolumab for 12 months, did fine. You have been following him up with serial cystoscopy and scans for, I think it should be 5. Let's just say 5 for more than 5 years. I think no, I didn't type that. So 5 years, 3 or 5, but anyway, for several years. His scans now showed lung metastases. You have sent a specimen for NGS, next generation sequencing for tumor profile, and that came back as follows. PD-L1 CPS less than 1%, HER2 by ILC 2+, fibroblast growth factor receptor alteration or mutation present, positive. So now, be ready, wake up. So now what are the, so please choose the best option of systemic therapy. So first choice is enfortumab Padcev with immune therapy pembrolizumab or pembro. So enfortumab and pembrolizumab. Second option, nivo with gemcitabine and cisplatin. So chemotherapy and immune therapy followed by maintenance nivolumab. Carboplatin and gemzar followed by maintenance avelumab. Immune therapy. Trastuzumab or FGFR, fibroblast growth factor receptor inhibitor, Palverza, which is an oral therapy. So choose one, please. Number 1, 5. جزاكم الخير more. Five. Number 1. Number 3. Okay, so let us go on the what we have data. So we try to be more academic and scientific based. So I know these drugs may not, they're not available for us, for you guys, but for sure we want to be up to date, and patient will ask us, and we need to be up to date on treating this disease because there is a lot of new data for bladder cancer. So systemic therapy for urothelial. Remember, all this is about urothelial. So these are the options of systemic therapy: antibody drug conjugate, ADC, immune checkpoint inhibitor, chemotherapy, of course, traditional chemotherapy, conventional chemotherapy, and targeted therapy. These are the options for stage 4. This is stage. So here are the this is just the outlines of the treatment for stage 4A. So there is no distal metastasis, no visceral metastasis, no liver or lung metastasis. The treatment is systemic therapy for 2 to 3 cycles, or concurrent chemoradiation. Remember, there is no distant disease. So you could use concurrent chemoradiation, reassess after 2 to 3 months, consider consolidation systemic therapy, or chemo-RT, or cystectomy. For patients with the stage 4A, that means M1A mets to the lymph node beyond the common iliac, so like retroperitoneal lymph nodes or so. So there is no systemic disease still. There is no systemic disease, there is no visceral metastasis. So the treatment is systemic therapy. If there is CR or PR, consider consolidative or local therapy. This is just outlines for stage 4B, M1B. So this metastasis, lung, liver metastasis, systemic therapy without palliative therapy. So there's no consolidative chemoradiation or cystectomy in this situation. So first line, you have a patient with metastatic disease, like our patients who has metastatic disease to the lung. So the first option, what is the first line? So the first line treatment is enfortumab Padcev plus pembrolizumab. But remember this, the patient has to be eligible. So is our patient eligible? This is the first line treatment, but if the patient is eligible, so we have to go to the patient history that I gave you. The patient has CKD, has diabetes, has extensive eczema. I did not put those for no reason. That's the reason we put them in the history. So you have to look at the patient history, look at the patient as a whole. So this is the first line if the patient is eligible. So if the patient is not eligible for enfortumab and pembro, which is the standard of care first line, or if the patient had no access to the drug like in Sudan, the drug, there is no enfortumab, there is no pembro, there is, these are not available, it's fine. So that means that the patient is not, is eligible, but does not have an access to the treatment. So still we have to give them option. So in that situation, and then we look at the second situation, and then ask ourselves, is the patient cisplatin eligible? This is how we answer this question for this patient. So if the patient has if the patient is cisplatin eligible, if the patient is eligible for cisplatin, then the option is nivolumab, gemcitabine, cisplatin for 6 cycles, followed by maintenance nivolumab, or any cisplatin chemotherapy followed by maintenance avelumab. So this is if the patient is eligible to cisplatin. So our patient got to the question. Our patient was not eligible for the enfortumab and pembro. Why? Because he has extensive eczema, not controlled, and he has renal insufficiency. He has diabetes. We don't know if it's controlled or not, but at least he has skin disease, extensive, that make him not eligible for enfortumab. And then, so the first line standard of care is not for our patient. The second question is, then we move to the second step. Is our patient cisplatin eligible? No, his EGFR was 39. So that means nivolumab option with gemcitabine cisplatin for 6 cycles followed by nivolumab in the question is not a correct answer because the patient was not eligible for cisplatin. Another option with chemotherapy maintenance nivolumab, no, that's not the right question and right answer because the patient is not cisplatin eligible. So now, if the patient is cisplatin ineligible, like our patient is not eligible for the first line enfortumab and pembro and is not eligible for cisplatin. So we have to give him another option. So the option, then we ask ourselves a third question and ask ourselves a question, is the patient eligible for carboplatin? If the patient is eligible for carboplatin, which is we think we don't have any contraindication. He doesn't have history of allergy to carboplatin because there's some patients they have allergic reaction to carboplatin. So if the patient is eligible for carboplatin, like our patient, assume he is eligible for that, then the option is gemcitabine, carboplatin, followed by maintenance avelumab, and that's the right question. That's the right answer for the question. So the right question here, we use carbo. Remember, we said never use carbo, but for patient with curative intention, like a new adjuvant. For patient on palliative systemic therapy, you do use carboplatin and gemcitabine, and we can follow up that with immune therapy and avelumab. And there was a randomized study for the avelumab maintenance. It showed that it improved overall survival 36 versus 30%. So this is a good option for patients not eligible for enfortumab, not eligible for cisplatin. So this is the best answer if the patient is eligible for carbo. If the patient is not eligible for carbo, so still we have to give him some option. Then at that time, we could use immune therapy by itself, which is pembrolizumab immune therapy. This is for a patient that is not eligible for enfortumab first line, not eligible for cisplatin, and not eligible for carbo. Then at that time, the option is immune therapy single agent pembrolizumab. But remember, for a patient with a creatinine clearance less than 50, should not be a contraindication to cisplatin in the systemic setting. And all we need to do that is try to relieve obstruction like what we have done for the new adjuvant. Try to reverse the obstruction and relieve and resolve the obstructive uropathy. So we try to do everything to make the patient eligible for cisplatin because cisplatin is known to be the most effective drug for conventional traditional chemotherapy for bladder cancer is cisplatin. So we have to do everything to give the patient the opportunity to receive that chemotherapy. So a little bit, few words about enfortumab. Abatsev. So the new drug, let's just know about it a little bit, what it is. It is an antibody drug conjugate, a Nectin-4 directed antibody, and microtubule inhibitor conjugate. So it is a drug. It is an antibody conjugated with the microtubule inhibitor. So it's a chemotherapy and an antibody, an immune therapy. It's a conjugate drug. So patients who are poor candidate for enfortumab, who are they? So do not use enfortumab for patients with uncontrolled diabetes, patients with severe dermatologic conditions, patients with severe neuropathy, patients with impaired renal function, like our patient. When we use the enfortumab and pembro, we use it based on this clinical trial. It was a phase 3 clinical trial, EV302. They enrolled more than 800 patients with locally advanced disease and metastatic urothelial carcinoma. They gave it was very simple study. I mean, just like the patient, two groups, two arms, enfortumab and pembro versus conventional chemotherapy, and they use gemcitabine and platinum, cisplatin or carboplatin if the patient is not eligible for cisplatin. And some patients, more than half of the patients, received adjuvant or receive not adjuvant maintenance avelumab. So here the results of the study. It showed that is the overall survival was 32 versus 16% with the hazard ratio of 0.47 and PFS 13 versus 6 months. All these are significant, and objective response was 68 versus 44%. So, and that's what led to the FDA or Food Drug Administration approving the drug to be used at the front line as the new standard of care. Cisplatin in ineligible patients, they have received carbo, and the subgroup analysis for this showed an overall survival for this group not reached yet for both. I mean, for the carbo versus 13 months, and the PFS was 11 versus 7. So even the carbo arm is actually show that is effective. But the all comers, you can see the result there, is all are significant for the overall survival, PFS, and objective response. This is just a design of the study. They divide here in there around more than 800 patients. They divide them in two groups. Very simple. Padcev with pembro versus platinum based, and they gave it until disease progression or unacceptable toxicities. This is here the PFS. You can see 12.5 versus 6.3, significant. And here, this is an overall survival is significant to 31 versus 16, it doubled. So again, if you use this, if you happen to use this the drug, you need to know that this drug is given regardless of platinum eligibility. So you don't need eligible for, you give it for all. And regardless of the PD-L1 status. So you don't need the PD-L1. The question is, you give us PD-L1 less than 1% just to confuse us, but it's not needed. You don't need. If you can see that we do not check PD-L1 stat for bladder cancer. In the old study for the atezolizumab, when it was approved, it was for the PD-L1 positive patient, but the zitulumab has been withdrawn for the bladder cancer by the pharmaceutical company. It is not in the list anymore, and we do not check PD-L1 status for the bladder cancer anymore. So if you happen to give this regimen, you need to give the enfortumab first, wait for 30 minutes, then give the pembro. This is the way it has been given. And enfortumab typical in the study, and in the study has been given until disease progression or unacceptable toxicity. However, in real life, everyone has been given the drug for certain number of cycles, 7 to 9 cycles, if tolerable, to avoid risk of cumulative neurotoxicity. So the design is for until disease progression or unacceptable toxicities. However, everyone has been given less than that. Give it for 7 to 9 cycles, but pembrolizumab is given for up to 12 months or until disease progression or unacceptable toxicity, whichever comes first. So this is how. So toxicity of this drug, just we need to talk a little bit about this drug. In the study, peripheral neuropathy be reported as this main side effect. The side effect: peripheral neuropathy, ocular toxicity, pneumonitis, cutaneous toxicity. It could be severe and life-threatening. Remember, this patient, what I gave you, has extensive eczema, not well controlled. So that patient is at risk for developing cutaneous toxicity. It could be life-threatening. The patient could develop Stevens-Johnson syndrome or toxic epidermal necrosis, which could be life-threatening. So that patient is not, our patient is not eligible for this drug because of a couple of things: the skin, CKD, and his diabetic. Hyperglycemia is one of the toxicity. Immune-related toxicity is not related to enfortumab; it is related to pembro. But in this study, they found that grade 3 toxicity actually is lower in the enfortumab pembro versus platinum-based, 56 versus 70%, and there was no new toxicity had been reported in the study. So it's a good choice for the right patient if the patient is eligible. So now, are we doing good? Are we doing fine, guys? I'm going to continue. Okay, so immune therapy and chemotherapy. Now, just move to that. So immune therapy and chemotherapy is nivolumab and plus chemotherapy. This is the phase 3 trial that was Checkmate 901. They enrolled more than 600 patients, cisplatin eligible patients, local advanced, and metastatic urothelial carcinoma. It was a study. This is the design of the study. They gave nivolumab plus gemcitabine and cisplatin for 6 cycles, followed by maintenance nivolumab for 2 years versus chemotherapy alone for six cycles. And here, after 34 months follow-up, nivolumab plus cisplatin found that improved overall survival 22 versus 19 months, PFS 7.9 versus 7.6 months. It increased the duration of CR 37 versus 13 months, improved objective response 58 versus 43%, and CR 22 versus 12%. And this has been approved now also for metastatic bladder cancer for patients who are not eligible for the first line enfortumab and pembro. This is your choice if the patient is cisplatin eligible. This is the study was published in the New England Journal of Medicine, nivolumab versus gemcitabine, and the conclusion was the combination therapy with nivolumab and gemcitabine, cisplatin resulted in significant better outcomes in patients with previously untreated advanced urothelial carcinoma than cisplatin alone. So become a standard of care for patients who are not eligible for enfortumab and pembro, and they are cisplatin eligible. And these are the overall survival curve. You can see the curve for the PFS and the overall survival, both of them separated and significant. So this has become a standard of care for those kind of patients. What about adjuvant avelumab after platinum? This came from the Javelin Bladder 100 trial. It was a phase 3 trial, randomized, open-label study, multicenter study in patients with unresectable, locally advanced or metastatic urothelial carcinoma that did not progress with the first line platinum. So you have to have a patient received platinum-based, not progress, either respond, CR, PR, or stable disease are all fine, any of the three. This is the design of the study. They give the patient 4 to 6 cycles of platinum-based, and then if the patient has achieved a CR, a PR, or stable disease, they give them a break of 4 to 10 weeks, and then after that, divide patient to best supportive care versus avelumab. And here is the overall survival. The curves are separated. It is 23.8% month versus 15 months for the best supportive care. So this is significant, and the drug has been approved and now standard of care for maintenance therapy after any platinum-based systemic therapy with the patient not progressing, either CR, PR, or even stable disease, you can give them avelumab maintenance. Now, these are the other options of first lines. If you don't have those options, if you don't have the enfortumab, pembro, or GEM, nevo, and these are acceptable options. They're okay options for it's a palliative treatment, either gemcitabine single agent, gem Taxol, or ifosfamide, doxorubicin, and gemcitabine. So this is another. These are all for first line. For second line and beyond, it depends on previous therapy. So if the patient prior therapy enfortumab and pembro, then your second option is platinum-based. It depends on eligibility for cisplatin. If cisplatin eligible, then you give them cisplatin-based. If not, carbo-based. If the patient has prior platinum and immune therapy, then you check for FGFR. So our patient that is positive, but remember FGFR, the fibroblast growth factor receptor inhibitor, not a first line. Remember, our patient, we talk about first line. That's why it was not a correct answer, because it was the first line. This is for patients who failed first line. So it is a second line. If the patient has to be exposed to first line treatment, whatever that is, but it has to be, this is a second line approval. It is not a front line. That's why the question was not right. That answer was not right for this patient, because our patient is the first line option. So for patients who receive platinum and immune therapy, we do check the FGFR, and based on that, we decide. Because this is a second line. So if FGFR mutation negative, your option, if enfortumab has never been used before, then it is your first option. Otherwise, your option is the Trodelvy, which is now actually in use for triple-negative breast cancer, but Trodelvy is a good option for patients who are FGFR mutation negative, or single-agent chemotherapy, cisplatin, Gemzar is fine. But if the patient FGFR mutation positive, that is, and being treated with previous chemotherapy, so this is second line, then your best option is Balversa, which is an oral targeted therapy. Of course, if the patient has HER2 positive IHC 3+, our patient was 2+. But in any case, this is not a first line, not a second. This is a later option. If the patient has been treated with all these options and failed, then your last option, and if they are HER2 positive 3+ by IHC, then HER2 or trastuzumab is your option. This is the phase 3 trial for Balversa. It was a SOAR trial. This is the cohort 1. They have two cohorts. This is cohort 1. This is the design of the study. They give Balversa versus conventional chemotherapy, docetaxel, and the other chemotherapy I have never used it. Only in I don't think it's available in the US. But anyway, it's conventional chemotherapy, Balversa, an oral therapy, and this is the design of the study. This is the first cohort. So the primary endpoint of the study was achieved. It showed this is the overall survival is significant. Cannot read it from here, but I think it is 12.3 versus 7.8 months. So, and then the PFS also is significant, 5.6 versus 2.7%, and the overall objective response is also significant, 35.3% versus 8.5%. So the drug is very effective, and now is approved as second-line systemic therapy for urothelial bladder cancer. Okay, now we go to our patient and see the answer, and these are the options. So the right answer is here. And let's just go over why these options are not the correct answer. If you can see, the enfortumab and pembrolizumab, we are not choosing this as the right answer, simply because the patient is not eligible for the drug due to the the fact that has CKD, renal insufficiency, and uncontrolled, poorly controlled eczema make him at high risk for cutaneous toxicity, which could be life-threatening. So we take that option out just because of the potential life-threatening toxicity. The second option, nivolumab, Genzar, cisplatin, we are not choosing this. It is a good option, but remember, cisplatin, this patient is not cisplatin eligible. So when you answer the question, look at the background of the patient. The patient has renal insufficiency, CKD, EGFR 39. So that's why it is a good option, but it's not for him because of the cisplatin ineligibility. Number 4 is not an option because this is this is actually a third or fourth line choice. So we're talking about first line here. So that's why it's not. EGFR, Balversa is not an option just simply because it is only used as a second line, and we're talking about first line. So we left with one option, which is the carboplatin gem, followed by maintenance avelumab, and we saw the study for these drugs, and this is the right answer. So after we have done all that, then surveillance for the bladder cancer is typically done by urologists. If it's early stage, they do serial cystoscopy, scans. But I mentioned this here because now molecular residual disease (MRD) for circulating tumor DNA is being in use. Actually, you could use it as a surveillance for your bladder cancer patient with a test called Signatera Detect, which is detect circulating tumor DNA. This is been in use for any disease of stage 2 and over. Few words about small cell carcinoma of urinary bladder. Just few words about that. For a patient with muscle invasion, we say that it does not affect treatment decision. For stage 2 and stage 3, we do use neoadjuvant, but we use the small cell regimen, which is the cisplatin etoposide followed by cystectomy for stage 2 and 3. So we don't use MVAC or GEM-CIS. We use CIS and etoposide, but still we use cisplatin, and we follow that with cystectomy. For a patient who receives cystectomy without neoadjuvant, adjuvant platinum base is reasonable. Remember, even this is a small cell carcinoma. PCI, prophylactic cranial radiation, is not recommended for bladder cancer squamous, for bladder small cell carcinoma, because for small cell cancer of the lung, we do use prophylactic cranial radiation for limited disease, but for the bladder cancer small cell carcinoma, PCI is not recommended. For metastatic disease, we use all the regimen that we have been using. We use for the small cell carcinoma of the lung. We follow the same path. So, practice changing from this presentation. Practice changing is a new standard of care, which is for metastatic urothelial carcinoma. First line therapy, this is the practice changing. Enfortumab, Padcev plus pembrolizumab or Keytruda is your standard of care for eligible, I have to say that, eligible patients for enfortumab. Then this is your standard of care, and this is considered a practice changing. And now the take-home message: neoadjuvant cisplatin-based chemotherapy. Remember, cisplatin has to be cisplatin followed by cystectomy, improve overall survival in muscle invasion urothelial bladder cancer, stage 1 or stage 3A, and this becomes standard. This has been a standard of care actually. So, and remember, do not substitute carboplatin for cisplatin in the neoadjuvant setting, because here your treatment is curative intent. TMT is only for patient not candidate for cystectomy or cisplatin, or patient desire to preserve the bladder. For the metastatic urothelial bladder cancer, again, enfortumab and pembro should be used as first line if available, and if the patient is eligible, this is new standard of care. For patients with the stage 3B and stage 4, run molecular genetic testing for FGFR, fibroblast growth factor receptor, and HER2 by IC, of course, the FGFR by PCR. I think this should be the last slide, unless if you want to go for the kidney or up to you. Okay, if you want to continue. I don't know what is the time now. 1:30.
لا شكرا دكتور شامي, very nice review. I think a lot of information now have been explained from your side. Practice changing trials have been shown from your side. We spend now 70 minutes. I think if we can receive some question, it will be very nice end for this lecture, reserving this my suggestion, yani, to leave the kidney cancer for another lecture, because we are going to cover in kidney cancer the adjuvant and metastatic side as far as I know. For early kidney cancer have been it have been given to them by somebody. If you could more, I would like to ask you if you concentrate on metastatic renal cell carcinoma, and also for heavily treated patient with renal cell carcinoma, and also the option, I think it would be a very good from our side. So some question. You see in the chat box, she asked you if Fortumab given every 21 days. This is the question.
Yes. Correct.
Yeah, right. So for more question.
Assalamu alaikum.
Alaikum salam.
Thank you, Dr. Elshami. Very nice presentation. I would like to ask about uricale adenocarcinoma. We saw a lot of cases in Sudan, especially in Adbara, in this year. Uricale adenocarcinoma.
Yes, sure.
عندنا في عطبرة تقريبا في السنة دي شفنا زي 3 أو 4 حالات بتاعت uricale adenocarcinoma. As you said, there is limited data and less responding to chemotherapy. يعني في 2 من العيانين مشوا مصر واخذوا تقريبا كيموثيرابي، وانا متابعه معاهم لكن شايفه there is partial response. واحد فيهم بياخد فولفوكس، ما عارفه ليه يعني.
Yeah, بصراحة يعني as you said, unfortunately actually adeno is even more rare than the squamous, and if you can see the data for squamous is very rare. Definitely for adeno is even rarer actually. So I would follow the same step like the urothelial, and I have seen an adeno here, and we just treat very similar to urothelial, but I'm not sure about the Folfox, but I would treat the same. I mean, especially with adeno, sometimes taxane, if it's metastatic, I think is reasonable, like a Taxol. I mean, this is all extrapolated from other type of cancers, but I don't think there is enough data. We just say we follow the same path like urothelial for adeno.
Yes, may I add on this area? Yes, the ideal management for this patient is surgical, or and surgically with radical or partial cystectomy. This is the ideal. Sometimes chemotherapy, radiotherapy, but they treat it as GI origin. You know, the source of it is urachal. So they decide to treat it with GI protocol. They are right to give him Folfox.
Like a GI IC. Yeah, makes sense.
More question? I think it's very rich information. Need to be followed by also questions. Question will make it very nice end, inshallah.
Can we give the question here, can we give pembro regardless of CPS? Yes, for urothelial carcinoma, if you remember, the first immunotherapy being approved and being used was the atezolizumab. So at that time, I remember we used to check we have to check the PD-L1 status and PD-L1 score. And then later on, actually, atezolizumab study did not, actually, the result wasn't actually holding, and the drug has been withdrawn to be used. So the pembro study was done regardless of the PD-L1 or CPS score. So yes, you give pembro regardless. So you don't need the PD-L1. That's why if you see that we said we check the PD-L1, we check the FGFR and HER2, but we do not check PD-L1 because the study has been done and proven that is regardless. However, in that study for the new adjuvant, they found that is the PD-L1 score is a surrogate for better outcome. But for now, we use it regardless of the PD-L1 score.
Okay, Mr. Shan, can I have a question regarding for those who receive new adjuvant chemotherapy, and the pathology came with residual disease? You said we give adjuvant.
It's okay. I didn't follow you. Say it again.
For those patients, you receive a bladder, receive new adjuvant chemotherapy. There is a residual disease. You said you can, the adjuvant option here is, one of them is nivolumab. So nivolumab will be given for patient with residual disease. For those who achieve complete pathological response after new adjuvant, still the option of giving him nivolumab is present, or we escalate?
No residual disease, you mean? They have new
complete. They receive adjuvant.
They receive new adjuvant.
New adjuvant underwent surgery. The pathology came as complete pathological response.
Only just a follow-up.
Yeah, I think, and this is in guidelines. It's not clarified clearly. They give for those patients who have they say like YBT2, YBT3 like this. So it is a residual, whether it is a lymph node or so. This area. I want to just clarify with you. It's okay.
Yeah. So if there is no residual disease, of course, there is nothing. Yes, yeah. These are for the people who have residual disease. Yes.
Okay. I think what I like from this presentation, the coming option for giving new adjuvant immunotherapy. You said based on pure 101 new adjuvant, pembro, and others. I think this will be the real changing practice.
That's correct.
A lot of patients.
Everyone is waiting for that studies. Yes.
So our candidates here should be alert if they see the practice changing dramatically. We omit chemotherapy now. Just maybe 1 or 2 years, 3 years, chemotherapy will be less in practice. Yeah.
I think probably in 5-10 years, probably going to be no chemotherapy.
Or less. You see, خلاص يعني صراحة we as oncologists we feel more comfortable when avoiding using chemotherapy with its horrible side effect. And you see, this raises the option that our candidates should read more about immunotherapy related side effect, because usually
that's why I suggested a lecture about it. because really we need to be aware of it, because really these drugs are becoming more and more in use. Look for pembrolizumab. Pembrolizumab have more than 16 indications. And these drugs are become more and more in use, even in the hematologic malignancy, lymphomas, Hodgkin lymphoma. And all of a sudden, it's going to be available. Even now, it's not available. It's going to be available all over the world. Like here, we use it left and right. And the problem is the side effects are unique. The drugs are new. The ER doctor, they don't know about the drug. The patient may come to the ER with diarrhea. They send them home with anti-diarrheal medication, or they come with dry cough. They say this is the flu, pneumonia. They send them with antibodies, and they die from it. So really being aware of the side adverse effect of immune-related toxicity is very crucial, and also medical legal is an issue. Because if you give patient an immune therapy, let them go home, they die from pneumonitis, you are liable. So we need to be aware, and we need to teach our patient and our doctor, the ER and internists, about this immune-related toxicities, because it is lethal, and at the same time, it's easy to reverse with just steroids. So if you are not aware of those side effects, if you don't know them, if we don't detect those side effects early, we really cause more harm.
Yes, I saw. Recently, the NCC guidelines show up a handover paper with different language, telling the patient the possible side effect from immunotherapy related side effect. They suggest to give him as after the patient completes his session, like what we do after chemotherapy, gives them a paper for those if he's living away, to give you to the nearby hospital, telling that the resident or the GP there that this is the possible, I am receiving chemotherapy or radiotherapy, and this is the possible side effect, so we can deal with the side effect effectively.
So,
okay.
In our practice, actually, we give our patients cards, just simple card, just to carry, to keep in their wallet, just to say that is to give. Say if you go to the ER for any reason, give this to your doctor. About say I have been receiving this, and these are the potential side effects. And you can even, we mentioned in the card that is my doctor recommend considering high dose steroid until proven it is not immunotherapy related toxicity, because the key is to start the steroid immediately. If you miss that immediately, then you lose, then the patient end up dying.
The problem here and even in the hospital, we notice that the other specialty is not aware about immunotherapy. For example, if the patient comes with nephritis, high creat, when they send patient to nephrology, you see they deal with him. It seems that they are not aware about the immunotherapy side effect, even GI consultation like this. So I think the other specialty need to be more aware about this type of treatment.
Yeah. Actually, we've been giving lectures to the primary doctors and the ER doctors. Actually, I have a ready presentation that I have been given to. I gave 3 times in our 2 hospitals to our internists and ER. If you like it, it's kind of like a 30 minutes presentation about adverse effect and what to look for and how to educate patients, educate doctors about it. And I could do that if you want to. I have it ready actually.
So
I gave it
this practice, you know, this practice is changing the idea about the other specialty about the side effect. So we can reflect it on our center. اوكي، في سؤال يا اخوة المشاهدون؟